The peritoneum reflects from its middle third to form double-layered mesentery of the transverse colon, the transverse mesocolon. The inferior or horizontal third part of the duodenum runs transversally to the left, passing over the capital I, capital V, capital C aorta and L3 vertebra. It is crossed by the superior mesenteric artery and vein and the root of the mesentery of the jejunum and ileum. Above to it, we find the head of the pancreas and its uncinate process. The anterior surface of the horizontal part is covered with peritoneum, with exception where it is crossed by the superior mesenteric vessels and the root of the mesentery. Posteriorly, it is separated from the vertebral column by the right sus major. The I, capital V, capital C, the aorta, the right testicular or ovarian vessel. The ascending part, fourth of the duodenum, runs superiorly and along the left side of the aorta, reaching the inferior border of the body of the pancreas. Just right there, it curves anteriorly, joining the jejunum at the level of duodenal-jejunal junction, taking the form of an acute angle, the duodenal-jejunal flexion, which is supported by the attachment of a suspensory muscle. Take a look in your atlas, the small and large intestine, in all the parts and review each one of them. Right. As you learn the description, draw the digestive system extending from the lips to the anus, where you can be able to find the small and large intestine, where you can be able to find the ileocecal region showing its blood supply. And as well, take a look at your atlas, right? All the figures contained to the greater omentum, the right colic flexure, the semicolli, the ascending colon, secum appendix, the inferior epigastric artery, the rectus abdominis, the urinary bladder, the ostra, the parietal peritoneum, the descending colon, the omental appendices, transverse colon. How the rectus abdominis is right as you get to see all these parts. At the same time, take a look the ascending branch ileocholic artery, the iliac branch, the anterior and posterior cecal branches, the iliocecal recess and fold, the superior part and the inferior part, the mesoappendix, the artery to appendix, the vermiform appendix. Take a look the relationship of the duodenum, right, with relation to the uncinate process, right, the portal vein, the gallbladder, the liver retracted, right, with respect of the vertebrae from L1 through L4, right, pancreas, kidneys, right. Take a look in your atlas, all the related uh, with the proper hepatic artery, the left gastric artery, the celiac artery trunk, the splenic artery, the common hepatic, the gastroduodenal artery, the dorsal pancreatic, right? The anterior and posterior pancreaticoduodenal arteries, the right gastromental gastroepicloic artery, the inferior pancreaticoduodenal artery, the superior mesenteric artery, the jejunal artery, which are anterior views. Right. Take a look at your atlas, right, around that area. The portal vein, the hepatic artery, the bile duct, the duodenal bulb, the supraduodenal artery, the pylorus, the gastroduodenal artery, the anterior superior pancreaticoduodenal artery, the right gastroomental artery, the anterior inferior pancreaticoduodenal artery, the right colic artery and vein, the ileocolic vein and artery, the mesenteric, right, the middle colic artery, duodenojejunal junction, the pancreas, the lymph node, the left gastric artery and vein, the esophageal branch. Take a look, the duodenum, the pancreas and spleen in your atlas. The celiac trunk, the left gastric artery and vein, the pancreatic magna artery, the splenic vein and artery, the inferior mesenteric vein, the superior mesenteric artery and vein, the common stem of posterior, inferior, and anterior inferior pancreaticoduodenal arteries, the lymph node, the horizontal duodenum, the ascending duodenum, the descending duodenum, the superior duodenum, the bile duct, the portal vein, and the hepatic artery. The ligament of Drake. This muscle is composed of a leaf of skeletal muscle from the diaphragm of a fibromuscular band of smooth muscle from the third and fourth parts of the duodenum. Contraction of this muscle widens the angle of the flexure, facilitating movement of the intestinal contents. The suspensory muscle passes posterior to the pancreas and splenic vein and anterior to the left renal vein. The duodenal arteries arise from the celiac trunk and the SMA. The celiac trunk via the gastroduodenal artery and its branches. The superior pancreatico-duodenal artery supplies the duodenum proximal to the entry of the bile duct into the descending second part of the duodenum. The SMA, through its branch, the inferior pancreatico-duodenal artery, supplies the duodenum distal to the entry of the bile duct. The pancreatico-duodenal arteries passes by the curve between the duodenum and the head of the pancreas and supply both structures. The anastomosis of the superior and inferior pancreatico-duodenal arteries, which occurs approximately at the level of entry of the bile duct, or, according to some authors, at the junction of the descending and horizontal parts of the duodenum. It is an anastomosis between the celiac and superior mesenteric arteries. An important transition in the blood supply of the digestive tract occurs. Proximally extending from the abdominal part of the esophagus, the blood is supplied by the celiac trunk. Distally extending to the left colic flexure, the blood is supplied by the SMA. The basis of this transition in blood supply is embryological. Take a look at your embryology books to check in as you are interested. The duodenal vein follows the arteries and drains into the portal vein, some directly and others indirectly, through the superior mesenteric and splenic veins. The lymph vessels of the duodenum follow the arteries. The anterior lymphatic vessels of the duodenum drain into the pancreatico-duodenal lymph nodes located along the superior and inferior pancreatico-duodenal arteries and into the pyloric lymph nodes that lie along the gastroduodenal artery. The posterior lymphatic vessels pass superior to the head of the pancreas and drain into the superior mesenteric lymph nodes. Efferent lymphatic vessels from the duodenal lymph nodes drain into the celiac lymph nodes. The nerves of the duodenum derive from the vagus and sympathetic nerves through the celiac and superior mesenteric plexus on the pancreatico-duodenal arteries. Take a look in your atlas, the jejunum and ileum. Duodenum, duodeno-jejunal junction, ileocecal junction, second, all the way. Take a look right at the encroaching fat, the vasa recta, the arcade, the windows, the vasa recta, the arcade. The jejunum and ileum begins at the duodenojejunal flexure and the ileum ends at the ileocecal junction, the union of the terminal ileum and the cecal. Together, the jejunum and ileum are 6 to 7 meters long, the jejunum constituting approximately 2 feet of the ileum, approximately 3 feet. Most of the jejunum lies in the left upper quadrant, whereas most of the ileum lies in the right lower quadrant. The terminal ileum usually lies in the pelvis from which it ascends. ending in the medial aspect of the sickle. Although no clear line of demarcation between the jejunum and ileum exists, they have distinctive characteristics that are surgically important. The mesentery, a fan-shaped fold of peritoneum, attaches the jejunum and ileum to the posterior abdominal wall. The root or origin of the mesentery, approximately 15 centimeters long, is directed obliquely, inferiorly, and to the right. It extends from the duodenojejunal junction on the left side of the L2 vertebra to the ileocoelic junction and the right sacroiliac joint. The average breadth of the mesentery from its roof to the intestinal border is 20 centimeters. The root of the mesentery crosses uh, successively the ascending and horizontal parts of duodenum, abdominal aorta, the capital I, capital D, capital C, the right ureter, the right psoas major, the right testicular or ovarian vessels. Between the two layers of the mesentery are the superior mesenteric vessels, lymph nodes, a variable amount of fat, and autonomic nerves. The capital S, capital M, capital A supplies the jejunum and ileum. Usually arises from the abdominal aorta at the level of the L1 vertebrae, 1 centimeter inferior to the celiac trunk proximally, and runs between the layers of mesentery, sending 15 to 80 branches of jejunum and ileum. They, the arteries unite to form loops or arches. Arterial arcades that give rays to stroke arteries, the vasa recta. The SMV drains the jejunum and ileum. It lies anterior to the right of the SMA in the root of the mesentery. The SMV ends posterior to the neck of the pancreas, where it unites with the splenic vein to form the portal vein. The specialized lymphatic vessels that absorb fat, lacteals in the intestinal belly, which are projections of the mucous membrane, approximately 0.15 through 1.5 millimeters in length, empty their milk-like fluid into the lymphatic plexus in the walls of the jejunum and ileum. The lymphatic vessels pass between the layers of the mesentery. The mesenteric lymph nodes are located to close to the intestinal wall among the arterial arcades along the proximal part of the SMA. Efferent lymphatic vessels from the mesenteric lymph nodes drain to the superior mesenteric lymph nodes. Lymphatic vessels from the terminal ileum follows the ileal branch of the ileocoelic artery to the ileocoelic lymph nodes. The SMA and its branches are surrounded by a periovascular nerve plexus through which the nerves are conducted to the parts of the intestine supplied by these arteries. The sympathetic fibers in the nerves to the jejunum and ileum originate in the T5 through T9 segments of the spinal cord. to enrich the celiac plexus to the sympathetic trunks and thoracic greater and lesser. Splenic nerves. The presynaptic sympathetic fibers synapse on cell bodies or postsynaptic sympathetic neurons in the celiac and superior mesenteric prevertebral ganglia. The parasympathetic fibers in the nerves to the jejunum and ilium derive from the posterior vagal trunks. The presynaptic parasympathetic fibers synapse with postsynaptic parasympathetic neurons in the mesenteric and submucous plexuses in the intestinal wall. In general, sympathetic stimulations reduces motility of the intestine and secretion and acts as a vasoconstrictor, reducing or stopping digestion and making blood and energy available for fleeing or fighting. Parasympathetic stimulation increases motility of the intestine and secretion, restoring digestive activity following a sympathetic reaction. The small intestine also has sensory visceral afferent fibers. The intestine is insensitive to most pain stimuli, including cutting and burning. However, it is sensitive to distension, and that is perceived as colic, spasmodic, abdominal pain. Take a look in your atlas, the rotation of the midgut, the midgut loop, right? The cranial limb and the caudal limb of it, the jaw sock, right? The dorsal aorta, the celiac artery, the elongated dorsal mesentery, the superior mesenteric artery, right? There are many different directions. You can take a look in your atlas along with the innervations and all the parts that we are describing, right? Take a look in your atlas, the mesenteric lymph nodes, how they are attached along the large and the small intestine, right? And take a look at how the lymph nodes are around the superior mesenteric arteries and how it looks. All these parts we are mentioning already. Um, the large intestine consists of the cecum, the appendix, the ascending, transverse, descending, and sigmoidal colon, the rectum, and the anal canal. The large intestine can be distinguished from the small intestine by Taenia coli, three thickened bands of muscles, the ostrum circulations of the colon between the taniae, the omental appendices, small fatty projections of the omental calipers. The intestinal diameter is much larger. The three Taenia coli bands of muscle fibers comprise most of the longitudinal muscle of the large intestine except in the rectum because the Taenia are shorter than the intestine. The colon has the typical circulated shape formed by the obstruct. There are no tinea in the appendix or rectum. Right. Take a look in your atlas, the contents, and what is for and made of all this large intestine. The terminal ileum and large intestine, including the appendix, the mucosa, the musculature, the aostra, the omental epiploid, the appendices, which are very well illustrated. The cecum and appendix. The cecum, the first part of the large intestine that is continuous with the ascending colon, is a bland intestinal pouch, for approximately 7.5 centimeters in both length and breadth. In the right lower quadrant, where it lies in the iliac fossa, inferior to the junction of the terminal ileum and cecum. If distended with feces or gas, the cecum might be palpable through the anterolateral abdominal wall. The cecum, usually lying within 2.5 centimeters of the inguinal ligament, is almost entirely enveloped by peritoneum and can be lifted freely. However, the cecum has no mesentery. Because of its relative freedom, it might be displaced from the iliac fossa, but it is commonly bound to the lateral abdominal wall by one or more cecal folds of peritoneum. The terminal ileum enters the cecum obliquely and partially invaginates into it. Traditionally, based on cadaveric studies, this is said to produce folds superior and inferior to the ileocecal orifice that form the ileocecal valve. The folds meet laterally to form which the frenula of the valve. When the cecum is distended and by assumption when it contracts, the frenula tightens, closing the valve to prevent reflux from the cecum into the ileum. And directly observation by endoscopy in living person does not support this description. This circular muscle is poorly developed around the orifice, therefore the valve is unlikely to have any sphincteric action in terms of controlling passage of the intestinal contents from the ileum into the cecum. The opening is usually closed by tonic contractions, however, giving it a papillary appearance from the cecal side. The valve probably does prevent reflux from the cecum into the ileum as contractions occurs to propel contents up to the ascending colon and into the transverse colon. The vermiform, which is vermis, worm-like appendix, a bland intestinal diverticulum, which is probably 6 to 10 centimeters in length, arises from the posteromedial aspect of the cecum inferior to the ileocecal junction. The worm-like appendix has a short triangular mesentery, the mesoappendix, which derives from the posterior side of the mesentery of the terminal ileum. The mesoappendix attaches to the cecum and the proximal part of the appendix. The position of the appendix is variable, but it is usually retrocecal. The cecum is supplied by the ileocolic artery, the terminal branch of the SMA. The appendix is supplied by the appendicular artery, a branch of the ileocolic artery, a tributary of the SMB. The ileocolic vein drains blood from the cecum and appendix. The lymphatic vessels from the cecum and appendix pass to lymph nodes into the mesoappendix and to the ileocholic lymph nodes that lie along the ileocholic artery. Efferent lymphatic vessels pass from the superior mesenteric lymph nodes. The nerve supply to the cecum and appendix derives from the sympathetic and parasympathetic nerves from the superior mesenteric plexus. The sympathetic nerve fibers originate into the lower thoracic part of the spinal cord, and the parasympathetic nerve fibers derive from the vagus nerves. Afferent nerve fibers from the appendix accompany the sympathetic nerves to the T10 segment of the spinal cord. The lymph and innervation of the large intestine. Lymph nodes for any part of the large intestine. The lymph nodes flows sequentially to epicolic nodes directly on the gut. Paracolic nodes along the mesenteric border. Intermediate mesocolic nodes along the colic arteries, ilio, right, middle, and left, and then to the superior or inferior mesenteric nodes that usually drain by intestinal trunk to the chyle cisterna colic nerves, parasympathetic lymphatic, parasynaptic sympathetic fibers from T10 through L2 spinal cord levels pass through thoracic and lumbar splanchnic nerves to postsynaptic neurons in the superior and inferior prevertebral ganglia. Postsynaptic sympathetic fibers travel along the colic arteries to reach the intestine. Presynaptic parasympathetic fibers from the vagus, CN10 nerves also pass along the colic arteries to the cecum, ascending colon, and most of the transverse colon. Presynaptic parasympathetic fibers from S2 through S4 spinal cord levels pass through pelvic splanchnic nerves to the inferior hypogastric pelvic plexuses and continues by way of nerves ascending from both right and left plexus. Only the right one is shown to reach the sigmoid colon, descending colon, and most of the distal transverse colon. Pain fibers from most of the large intestine follow the sympathetic fibers retrograde through sensory ganglia of spinal nerves T10 through L2. Pain fibers from the distal sigmoid colon and rectum following the parasympathetic fibers retrograde to sensory ganglia of spinal nerves S2 through S4. Take a look in your atlas, the nerves, the lymph nodes we are talking about, and the blood vessels of the large intestine and appendix. Right? One, two, three,